residency as postgraduate residency program director for the McGill Department of Family Medicine. He's been the coordinator for family medicine at St. Mary's. He's been undergraduate and postgraduate training director. He's won so many awards. It's hard to count them. He's like, for example, in 2007, he won the inaugural Prix d'Excellence for Advancement Teaching Family Medicine by the Quebec College of Family Physicians. He still has an active practice at St. Mary's Hospital. And as a clinician scientist, he is prolific. He has published 116 articles, 96 in peer-reviewed journals. And he publishes on a broad range of topics. So I know Mark for our collaborative work on elder mistreatment. And the elder mistreatment world is a world which knows and recognizes Mark very well for his contributions and for his leadership. But today we're going to be talking about something else. So the topic today, the title is Adaptation and Outcomes of Lay Mental Health Self-Care. And what's interesting here is that Mark's going to be presenting on a body of work that guided self-help for depression and anxiety, but it's the body of work, which is the combination of a number of, I think it's six trials, Mark?
That's right.
For people who are affiliated with the PBRN, if nothing else, it'll be interesting to explore what makes for a successful researcher-clinician partnership, which I think Mark's going to touch on. So without further ado, Mark, please take it away.
Thanks very much, Michelle. I'm very pleased to make this presentation today. I'm going to play around a little bit with the slides because I'm using a computer that I'm not familiar with. In any event, so the title of today's presentation is the Direct Care Model, Adaptation and Outcomes of Lay-Guided Use of Mental Health Self-Care Tools, the results of 6 studies. In terms of conflicts of interest, I identify none. You see on the screen various organizations that have provided research funding: FRQS, Canadian Cancer Society, Foundation for Advancement of Family Medicine, Foundation of the Canadian Medical Association, St. Mary's Hospital Foundation, and CIHR. None of them have been associated with any conflicts of interest, and I receive salary support from McGill and St. Mary's Hospital Foundation. In terms of disclosures, the first disclosure I would make is it's a little bit unusual for me to be presenting the summary of, or the collection of studies that we have done, since this was in large measure a major team endeavor over a 10-year period, for the most part led by Jane McCusker, our scientific director at St. Mary's for many years, and a member of the McGill Epidemiology and Biostatistics department. On the screen, though, I list a number of our major collaborators to give a sense as to the interdisciplinary, multidisciplinary work that this entailed. Sylvie Lambert from McGill Nursing and St. Mary's, Martin Cole from McGill Psychiatry and St. Mary's, Aaron Strumpf, McGill Economics, Epidemiology and Biostatistics, Tamara Sussman from McGill Social Work, Maida Seawich, McGill Epidemiology, St. Mary's and the MUHC, Antonio Ciampi, McGill Epidemiology and Biostatistics and St. Mary's, Jeannie Haggerty, McGill Family Medicine and St. Mary's, Hannah Schwartz, McGill Psychiatry and St. Mary's, Rosanna Faria, McGill Psychology and St. Mary's Oncology. From the University of Toronto, Jennifer Jones, Psychiatry and Public Health, Madeline Lee from the University of Toronto with expertise in psychosocial neuroimmunology and psychosocial oncology. The work that we did involved various collections of these people, various combinations, and the success that we had was in large measure a function of these individuals being able to collaborate and work together to a common goal. As far as further disclosures are concerned, I would admit that as a clinician scientist, I struggle with statistics. But when one is surrounded by the array of talent and expertise that I've just listed for you, one can get away with various weaknesses. And that is in part one of the real strengths of these interdisciplinary activities, and the respect that people have for each other and the opportunity to, in fact, learn from each other. And my relationship with these established researchers has aided my own ongoing involvement with this body of work, and independent of the work has been a source of education for me. And I don't want to downplay that, because I think in many cases I have learned more from others on the team than I actually gave in terms of input. Further disclosure, Dr. Wilczewski has already mentioned that our group this year received the Outstanding Care and Integrative Practice Award from the Canadian Association of Geriatric Psychiatry and the Canadian Coalition on Mental Health. And this was given to us in recognition of this 10-year activity of work in which we approached anxiety and depression from a number of different perspectives, and these perspectives involved bringing in people from various disciplines. And it was this interdisciplinary work that the award givers were particularly enthusiastic about the work that we did. So how did we start off? We had a problem, a question, and that was that depression and anxiety are common problems, particularly in those with chronic physical conditions and possibly pain, and that such symptoms or illness have a negative impact on patients' quality of life. And it's clearly recognized that some of these individuals would benefit from psychological treatment, which we know can be effective, but it's not necessarily easily available. In the public sector, there are administrative obstacles to getting mental health care, insufficient trained personnel, various services that are available are siloed and don't communicate with each other. And as a result, some people gravitate to the private sector for mental health care, but unfortunately it's expensive, and there is little monitoring of the quality of services provided under the private sector. What was a possible potential solution? We looked at the issue of supported mental health self-care. Why? Because it's low intensity, it's a psychological intervention, and based on principles of cognitive behavior therapy, or CBT, and it promoted learning to better understand one's depression and anxiety. And if one is engaged in such intervention, there's the opportunity for problem solving, behavioral activation, assuming that one follows structured goals, and that there hopefully is going to be some cognitive restructuring. That is the challenging of negative self-talk that many of us undergo when we are not feeling well. Respecting that CBT orientation, our team developed an innovative model of guided self-care tools to be used by individuals supported by trained lay guides. Our project, known as Project Direct SC, SC talks about self-care, refers to self-care, and the word direct is an acronym that describes our overall view of depression intervention via referral, education, and collaborative treatment. And so it was under that rubric of Project Direct that we conducted 6 different studies that I'm going to briefly discuss with you. In overall summary, these interventions consisted of toolkits that were either paper or web-based, that involved lay telephone guidance, and or what we in the COVID era referred to as virtual care. This was begun long before COVID provided the incentive for people to actually conduct mental health care over the telephone. Another principle of our work was that we adapted and tested our tools for different target populations, older adults with chronic illness, cancer patients, and so forth. So what is Direct, in fact? An overview of our program showed that we had full-powered trials and pilot trials, and I'm going to discuss a few of these today, but I'm not going to describe any one in particular detail. It's sufficient to say that there were 6 different programs that have resulted in over 10 peer-reviewed publications resulting from our multidisciplinary team, and 4 of them are listed on the screen, involving different populations that I'll be discussing with you in a moment. Our work required not only having tools to give to people who might require them to deal with symptoms of anxiety or depression, but also our hypothesis that the introduction of lay guidance may improve the outcomes for individuals, or may improve their appreciation of the tools at the time or in the future. And so we had, as a member of our team, a psychologist who had a responsibility to train guides, and I'll talk about those in a moment, and also to monitor the guides, and monitor the guides by conducting ongoing fidelity assessments, listening to audio tapes made of the interventions between the guides and the participants in the study. Who were the lay guides? These were non-professional people who we identified as having strong interpersonal skills, and those who had strong organizational skills. The target population that we asked them to become involved with in any of the studies were individuals who were pre-screened for mild to moderate symptoms and were not receiving professional therapy. Depending on the study, as we operationalized it, the different studies were of different duration, and so there could be an intervention that ran anywhere from 6 to 26 weeks that involved guided phone calls that ranged anywhere from 6 to 15, depending on the study, and the length of the telephone calls ranged anywhere from 10 to 15 minutes per call. A specific limited role for the guides was that they would not conduct therapy. They would orient the participants to the tools. They would assist the participants rather, in selecting the appropriate tools for their needs, and to assist the participants with setting appropriate goals. This study lists the PowerPoint lists the 6 studies in which we adapted the model for 6 different populations. The first was a study called Direct-SC that involved older primary care patients with chronic physical conditions and comorbid depression. We had a study called CanDirect, in which cancer survivors with depression were our target population. In general, people with cancer are relatively well followed during the course of their cancer care, which usually lasts about 5 years. And at the end of that time, they are, for the most part, discharged from the various oncology support programs and are left to their own devices. And the literature indicated that cancer survivors still had symptoms that required help. And so it was useful to study cancer survivors. We had a study, CVD stress, which looked at cardiovascular disease patients who were experiencing stress and studied whether our tools would be applicable to them. The Empower study looked at mothers who had postpartum depression or anxiety. We had PanDirect, which was a study directed to medically ill older adults during the COVID-19 pandemic. We had a final study called Coping Together, which aimed to provide the intervention to not only the patients, but also their caregivers when individuals were receiving cancer care. In all of these studies, the self-care tools and the guidance that was provided was given either in French or in English. So let's look at these studies very briefly. The initial studies for Direct SC and for CanDirect used what we called a toolkit that consisted of core CBT-based tools that were workbooks and self-monitoring tools. It included information tools addressing other common self-care problems adapted to specific population needs. For example, we addressed exercise issues, nutrition issues, difficulty in sleep, use or misuse of medications. And the toolkit media could have been accessed either in a binder of paper tools or using audio and video compact discs, and in some cases, going to refer to websites. Looking at our core tool, the Antidepressant Skills Workbook, this is a fairly well-known tool that was developed in British Columbia. Best known author is Dan Bilsker, and it is a tool used for information and skill building. And in going through the workbook, it provides individuals with details on depression, its causes and symptoms, strategies for using principles of cognitive behavior therapy, and then gave the participants various exercises to do and space to write down goals that they set for themselves that hopefully would direct them to realistic thinking strategies and to use some of the problem-solving techniques. The Bilsker workbook is available either in paper form or recently in an audio CD. The other core tool was a mood monitoring tool. And as you see on the screen, it's not rocket science in any sense. It allows individuals on a daily basis, 3 times a week, 3 times a day rather, to document the extent of their mood and to make connections between what was happening in their lives that day and various feelings. And this would hopefully give them some motivation to make behavioral changes that might be useful to them. This paper tool was adopted by an online tool that Stephen Grover here at McGill has used for some time in his health checkup stress diary. So it was quite appropriate to be incorporated into our studies. There were other self-care studies that we did. I mentioned that there were 6, and they were of different duration. One was PanDirect, the one that was done during the pandemic. It was a shorter study, and therefore we provided them with a smaller toolkit that only involved 2 tools per patient, having chosen tools based on their various symptomologies, having used the PHQ-9 and the GAD-7 screening tools for anxiety and depression to dictate where their particular emotional needs may rest. Study Empower. This was a study, as I mentioned earlier, on website to work with moms and to try to deal with postpartum depression and anxiety. The Stress and Cardiovascular Disease was a website-based study. CBT modules were used to try to reduce stress and worry in individuals who are at risk for coronary artery disease. And then finally, the Coping Together study that I referred to earlier for the cancer patient and his or her caregiver. I'd like now to briefly discuss each of these studies, and we can compare and contrast a little bit. We had the Direct SC study, which was primary care patients age 40 and above with chronic physical conditions and comorbid depressive symptoms. We conducted a pilot study of the intervention, specifically to see whether use of the toolkit with guidance or coaching could be done. And when that was demonstrated to be effective, we proceeded to an RCT of the intervention against an active control in which the toolkit was used in the absence of guidance. what did we find? We found that the addition of guidance reduced depressive symptoms significantly more than use of the toolkit alone, that patients receiving counseling at baseline from somebody other than our group did not benefit from the intervention. This was unexpected, but it suggested that the two strategies, getting help from a psychologist versus getting help using CBT tools, might have been at odds with each other. And as a result, in the future studies that we conducted, patients who were receiving counseling but were otherwise eligible were not included in the study. We observed that guidance increased the use of the toolkit under the conditions that I've just laid out. The CanDirect study, this was a pilot, like the other study was, with the toolkit and guidance, which was adapted for the specific needs of cancer survivors with mild to moderate depression. And it was very clear that the cancer patients needed different toolkits or different questions to follow, given the particular disease that they were dealing with. Following the pilot study, we conducted an RCT of the intervention, that is the toolkit plus guidance versus usual care. And at 6 months, the intervention group reported lower depression, anxiety, and depression diagnosis, and greater quality of life and greater activation. PanDirect study. The PanDirect study was a short pilot, an abbreviated version of the intervention that I have listed before, conducted solely over 2 months using a small toolkit and a maximum of 3 guidance calls. The control group received the toolkit, which consisted of the two tools only, and our goal was to assess feasibility and acceptability during the COVID-19 pandemic, keeping in mind that during the pandemic, access to psychological support was probably at its lowest, no matter how poor it existed in the community prior to the pandemic. Accessing mental health services during the pandemic from the primary care setting was discouragingly low. In this study, we did not screen for minimal level of mental health care, and we can talk about that later if there is time. Our findings show that the guidance that the lay individuals provided increased our patient engagement with the toolkit. And on the other hand, we did not see any significant effect on mental health symptoms. Empower. This was our pilot RCT. We did a RCT of telephone coaching and self-care delivered on a web-based intervention for mild to moderate postpartum depression and anxiety compared to use of the web-based intervention alone. It was observed that the intervention was acceptable to the women postpartum and certainly feasible in the population that was identified. The guidance group completed a mean of 6.2 calls with high fidelity. The guidance group made significantly greater use of the web-based intervention, and 6-month outcomes indicated trends towards potentially effective outcomes. The cardiovascular disease and stress study. We conducted a pilot study, again, of an adapted web-based intervention, this time for stress in adults with cardiovascular disease. And the patients who participated were those who, through screening for eligibility, were found to have significantly high levels of stress symptoms. We conducted an RCT of the web-based intervention alone versus web-based intervention with lay guidance. And with a little bit of a difference now, at 6 weeks, they were assessed for their symptoms. And if the symptoms were higher than expected, they were provided with increased support from specialized nurse practitioners using motivational interviewing. The studies found that guidance led to increased satisfaction, enhanced retention, and adherence to the tools that were available. The effect size for stress and the quality of life exceeded clinical benchmarks in participants who received guidance throughout the course of the study. The final study, Coping Together, was a pilot of an adaptive dyadic coping and self-management skill training intervention for individuals with cancer and their caregivers. The participants were screened in advance for anxiety, and they were provided through an RCT of booklet-based skill training materials that they could use alone versus those who had the materials and received the guidance. And like the previous study, if their symptoms are at significant levels, as the study went on, by 6 weeks, they were provided with increased support outside of the study protocol. What did we find? The telephone guidance model for dyads is feasible and acceptable, but likely requires further adjustment because of the various individual needs that the participants had. In some cases, they were able to work closely together. In other cases, it looked as if the tools might need to be modified to meet the needs of the actual individuals. And as well, the timing of use of the tools may have been a factor. Let me give that again. The timing appeared to be important in the sense that one of the members of the dyad may have had needs earlier or later than the other member in the dyad. We did analysis of the effects of guidance and is ongoing. Patients and caregivers in the active treatment group may prefer starting without guidance, including guidance support on a needed basis. And this was somewhat unexpected and suggests that a stepped care model may be the way to go for individuals who participate in dyads rather than as individuals in using the tools here. This PowerPoint shows the summary of mean guidance calls for each study. In the direct SC, which was conducted over 6 months, there was a mean of 10.3 calls. In the cancer CanDirect study over 6 months, the mean of 7.8 calls. In the pandemic CanDirect of 2 months, only mean of 2 calls in that time period. In the Empower study of 6 months, 6.2 calls. And that was the postpartum study. In the stress and coronary artery disease, at 6 weeks, there had been a mean of 4.1 calls. And in the dyadic Coping Together cancer study, at 6 weeks, the mean number of calls was 4.3. So there is some variation, and we can perhaps talk about that later. So how do we understand the effect of this work, the effect of direct? All 6 studies reported on the effect size. And as I mentioned at the outset, I'm not a statistician and I'm not very good with statistics. And therefore, I sympathize with anybody who's in my situation. And therefore, I have inserted a couple of definitions just to remind ourselves of what we're measuring. We looked at effect size, which is a standard measure of how much the studied outcome, in this case, depression scores, differed between the 2 groups studied. Excuse me. For example, intervention versus non-intervention, or tools or guidance with tools versus tools without guidance. The larger an effect size, the more substantial the effect of the intervention on the outcome is. And we can look, therefore, an effect size of 0.2 would be seen as small effect, 0.5 as medium effect, and 0.8 and above as being large. The other statistic of note, of course, is the 95% confidence interval, which provides the range within which we can confidently feel where we can reasonably confident that the true effect size lies, and that there is reasonable confidence that the observed difference is not due to random choice. Again, for those who are not statistically oriented, if the interval includes 0, it suggests the effect size is not statistically significant. If the interval is narrow, it suggests a more precise estimate. Hopefully we've gotten that little bit of statistics out of the way. And now we can look, wrong way, sorry. So if we're now looking at the actual effect size of various studies, and we look first of all at the direct SC study, which looked at comparing depression outcomes in patients using the tools with coaching versus or guidance versus those using the tools alone, the effect size was 0.44 for depression scores, and that value is considered to be a moderate effect. That is, that the coaching intervention did have a meaningful impact, though not extremely large. The confidence interval is shown between 0.08 and 0.77. The interval is large, but it does not include 0, and the effect is statistically significant, but not likely due to random chance. Looking at the effect size on the majority of our work, we tried to bring everything together and see, of all the studies that we did with their various differences, what effect size could be indicated. And so remember that the effect size is a standard measure of how much the studied outcome differed between the two groups. And this looks like a slide that I've already shown. As I said, this computer is not one that I'm familiar with, so bear with me while I try to see what I'm doing here. Okay, this is the one I was looking for. Sorry about that. I'm sitting in a room in the Laurentians outside of Montreal in a retreat, and they have given me a room to talk in, and it's not the most conducive for giving the presentation. In any event, the slide here looks at the summary of the effect sizes, either for depression and anxiety in the other studies of our program. And we looked at the effect size for depression outcomes for all studies, with the exception of the CBD stress study, because that study looked at anxiety. So in the following studies, the effect of guidance on depression outcomes was small to medium, but not statistically significant. And that included the Empower, the PAN-Direct, and the Stress CBD. But these involved active tools as controls as pilot studies. We see that the effect size for Empower, 0.45. For PAN-Direct, 0.12. Stress and CBD, 0.38. And you can position those within the confidence intervals shown. The effect of the intervention for CAN-Direct, the RCT of coaching with tools versus usual care, was stronger and was statistically significant, 0.66, found between confidence intervals 0.39 and 0.94. We did a pooled analysis of the 6 studies using a meta-analytic approach. In 3 depression studies with homogeneous outcomes, the pool effect sizes of guidance versus self-directed use of tools was 0.36, which fell in between the confidence intervals of 0.10 and 0.62, and a reasonably large N of 235. If we look at studies in which anxiety was also examined, there were 4 studies with homogeneous outcomes, and the pooled effect size of guidance versus self-directed use of the tools was a 0.21. And looking at the confidence intervals, it was between minus 0.03 and 0.44. Therefore, just non-significant. But the interpretation and the reason it was included here is that it was believed that in the Coping Together study, there were a number of operational issues that impeded the participants, and that if those had been attended to, the likelihood is that the figures would be within the confidence intervals. The things I'm talking about, I mentioned earlier, the timing being different for the 2 members of the dyad, the need for one of the participants to spend longer or shorter time on a particular tool, differences of opinions that they shared with each other and weren't able to necessarily resolve. So what do we conclude from this overview? The overview consisted of 2 fully powered RCTs and 4 pilot studies, and they seem to suggest that lay guidance model using CBT-based self-care tools have features that are generalizable to different populations with mild to moderate symptoms of depression and or anxiety and stress. And we could also conclude that there's evidence that these tools do, the use of tools with guidance increases engagement with self-care tools and overall reduces mental health symptoms. We also conclude that, for example, in the case of the PanDirect study, this was an intervention that was found not to be effective with people with physical illnesses because the participants actually did not meet the threshold for mental health symptoms. We made some assumptions that these individuals with chronic illness who are having difficulty seeing their doctors and seeing mental health support workers, that they would have a significant enough degree of mental health symptoms to benefit from our study intervention. In reality, however, their scores on anxiety and depression actually were really quite low and within the range of the normal population. Continuing our conclusions, we suggest that the optimal number of guidance calls is probably between 6 and 8, conducted somewhere over a 6 to 12-week period, but this may vary by population and more research is needed. Excuse me. The participants in our study were skewed to a female educated or better educated population. The support for the didactic self-care had challenges, as I've already talked about, and it's likely that the lay guides need more support for how to deal with those challenges, that more timing for phone encounters would be needed to address problematic issues, and that the differences between participants in terms of time needs and times to do the dyadic activity may be a target for future research. We believe that our research has shown that this is a potentially sustainable alternative to therapist-delivered interventions, and in some cases, there may be potential for use in a step care approach for delivering mental health services to a population. step care might be starting with self-directed tools without guidance and progressing to self-care tools with guidance for those who are not responding. That was not a methodology that we used in any of our studies, but the outcomes suggest that it probably would be a good idea. Where does the clinician scientist fit into this kind of research? I showed you at the beginning the large number of participants from different professional backgrounds. And then along come a family physician scientist who may not have the expertise that other people on the team have, or that they bring specific expertise. And one of the areas that we observed that clinician scientists, family physicians could play was in looking at the issue, first of all, in helping to interpret the data in each of the studies. And that was certainly true for any of the participants. But we saw a particular area in our discussion about knowledge translation. The question was raised early on: can family physicians be the guides? Why do you need to employ lay individuals to do this? So over the course of some of our work, I explored 28 possible mediating factors for family physicians to be the guides. And these included factors such as the personal qualities and communication skills of the family doctors, their attitudes to self-care, issues in the pre-existing doctor-patient relationship that may impede self-care, in the sense that many doctors are not accustomed to giving their patients the opportunity to be selective in what they do. The doctors give advice and leave it at that. There may also be, for the family doctors, difficulty in timing to meet with their patients to deliver self-care in the way that we've described, because of their working hours and the times in which the patients would be available to engage in self-care guidance. A good number of these took place in hours that are in times when the family doctors would not be available. Also problems in the fact that this type of activity may not be remunerated by provincial payers. And there may be family physicians whose attitudes to mental health problems may make it even more difficult to provide guidance under these situations. There have been exceptions. There has been a project in selected family medicine practices in British Columbia where doctors were paid in advance to participate in learning sessions to be oriented to giving self-care guidance and to trying to incorporate it into their practices. The doctors were self-selected. The pay was compared to what we know here in Quebec was certainly quite generous. And it's not likely that that kind of orientation would be possible to replicate in Quebec. And the assumption from all of this is that there are certain deficit and some likely probable obstacles for family physicians in other sites to become guides for their patients. Another role for clinician scientists continuing to look was the continued exploration of where and how this type of program could be implemented. And so I participated in discussion groups and interviews with stakeholders in CLSCs, in GMF and GMFUs, and various disease organizations. Disease organizations meaning the Canadian Cancer Society, a rheumatological society, the Society for Parkinson's Disease, and so forth, to find out whether they would be interested to be partnered in these kinds of activities. Almost invariably, the response was positive, enthusiastic, but nonetheless, each identified operational, legal, financial, and manpower issues that suggested obstacles to integration of these kind of models that we have studied.
Sorry, Mark, are you going to be finishing? Because I want to allow people some time for questions.
I am. This is the last slide.
Perfect.
And the last, your timing is excellent. Just to say that materials for these studies are available at our research center at St. Mary's Hospital through Manon Durad, along with our publications and summaries. So you got me at the right time, and yes, we're done.
Thank you so much. That was really interesting. And yeah, a lot of work that took place over how many years? When did the first one start?
10 years.
10 years. Wow, a decade of work. I want to throw it out to the audience. Does anybody here have any question for Dr. Yaffe? Don't be shy.
I'm just going to say great work. Thanks for the presentation.
Thank you.
So I had a question, but your knowledge translation to clinicians was basically what what my question. Oh, Michael Klein has a question. Go ahead.
Hi, Mark. Nice to see you.
Nice to hear you, Michael.
Calling from British Columbia. It's quite an impressive body of work. Congratulations. I guess it illustrates how within family practice, you have to focus on a particular content area to become the kind of expert that you become. I have a question about the process between the tool and the counselors and the patients. How do you identify somebody who requires more than the research model provides? Somebody who slips into a more severe depression or mental health issue, and what do you do about it?
That's a great question. Let me just respond to your original comment, Michael, and then I'll answer the question. Your observation about family physicians needing to find a niche. I'm going to share that for the first I don't know how many years of my career, I resisted having a niche. Because as a generalist, there were all sorts of things that interested me and that I wanted to look at, and didn't want to get caught up in the traditional model of having to have a niche. That was sort of the first 15 to 20 years of my practice or my career. That reality broke down when it became important for grants that you did have to have a track record in some area. But I could get away with a limited track record, again, by being part of a team that did have the track record, and that in the grant applications, we tried to specify the particular contributions that I might be able to make. Nonetheless, I have found 2 or 3 niche areas, and now at the sort of tail end of my career, I am moving away from that niche again to try to study things that just are of general interest to me before I have to step down and forget about doing this stuff. In terms of the question about seriousness of symptomology, the patients are all initially screened in these studies for greater than moderate symptomology. When they are referred to the psychologist associated with our program, who is mandated to do a further assessment of the severity of the mental health problem. And if it indeed was serious, to that extent, they were not admitted into the study because we were studying mild to moderate, and they were referred on to a community or hospital resource. During the course of this study, the guides were trained to look for warning symptoms, and they were periodically in some of these studies. They had PHQ-9 and GAD-7 scores done intermittently through the study to monitor ongoing for morbidity that wasn't being picked up by the guides. The third opportunity came from the guides themselves, asking the psychologist to do a targeted audio review of the encounter that the guide felt was problematic in order to get the psychologist more involved.
May I ask a follow-up question?
Sure.
Can we let Dr. Issa ask her question first?
Sure.
Oh, it's okay. It's not about, but all right. Thank you, Mark. That was a very impressive presentation and an amazing body of work. Thank you for presenting it. The one thing that strikes me as being kind of, and well, there's two things that strike me. One is that using lay guides is in some ways very avant-garde in some ways, because of the fact that we, as we all know, the state of mental health treatments are unfortunately quite lacking. But one of the things that's I wonder about, and maybe I wonder if you've thought about it, is kind of the next steps for something like this, which may be studies related to medical wearables, because of course medical wearables nowadays they're increasing by the day, and yet there have been increasing interest in medical wearables with various mental health treatments. So I'm wondering if you can address whether that's something that you and your team have thought about, and if so, what kinds of plans you have for the future. Thank you.
We have not thought about it. This was sufficiently preoccupying that we have not. It's clear that there are other ways to provide care for mental health that does not come from the traditional caregivers, and that involves technology. I was asked recently to review a paper in which an artificial intelligence intervention was being studied, very similar to what we were doing, but using artificial intelligence. And as an early study, there were some very interesting findings. I don't think the paper will be published soon. There were significant problems with it, but it did suggest to me that we need to think outside the box for this kind of thing.
Thank you.
Dr. Klein, your follow-up question?
Yeah, I'd like to know a little bit about the acceptability from the participants in the study, and further, your own, forgetting the study for a moment, and your own assessment of the utility in everyday practice of the methodology that you used.
I'll start backwards. The utility of it in everyday practice, you mean using me as a guide or me referring patients for this kind of thing?
No, not any family doctor, not you particularly.
Right.
Can you see it evolving into a tool or an approach rather that could be used within primary care?
Well, that was the expectation when we started this work. But there was always the question of how it would be actually implemented. Who would implement, who would be responsible, who would recruit the lay guides, who would monitor them, who would be their professional backup. And we even went to the point of meeting with some representatives from the Ministry of Health and Social Affairs to get a bigger sense as to what the system might be prepared to expand. We discussed this with people working within CLSCs, and almost invariably in those discussions, there was a fair amount of negativity, not because of the intervention, but because they were not optimistic that the system would want to deviate from the mental health model that it currently practices.
So what do the subjects feel about the interventions?
The subjects were exceptionally enthusiastic. In most of the studies, the acceptance was high. In the case, for example, in the PanDirect study, where we only did the 2-month intervention, one of the positives that came from it was many of them hoped to retain what they had learned to be used under other health situations. So the content is certainly generalizable to many things that go beyond symptoms of anxiety and depression, but they were aware that they go through mood swings, and the majority said they hoped to be able to use them in the future.
Thank you.
Does anybody else have any questions for Dr. Yaffe? Okay, well, Mark, this was fascinating and inspiring, and I'm very happy to have been part of this, and it was a delight for me to be able to introduce you, given our relationship and our working relationship. So thanks everybody for being here. Anya, do you know the topic for the next seminar by chance? Sorry to put you on the spot. Sorry.
No, not offhand.
Okay.
Sorry.
Well, I'm sure there will be a communication.
It's May 23rd.
Okay. All right. So it's in a couple of weeks, or in 20 days. So thanks everybody. Wishing everybody a good weekend, and congrats, Mark.
Thanks very much.
Thank
Appreciate
you, Dr.
being invited.
Yaffe.
Pleasure.
Have a good weekend, everyone.
Bye-bye.
Bye.